voice is through the MacBook. Sorry for that. اسمعوني دكتور منصور، دكتور اسماعيل.
Okay. شكرا جزيلا دكتور مرشد. I need to invite the other the next speaker, دكتور إبراهيم النظاري. دكتور إبراهيم, you are welcome. تفضل.
السلام عليكم ورحمة الله وبركاته. تسمعوني؟
نعم.
السلام عليكم ورحمة الله وبركاته. أساتذتي الكرام، زملائي الأعزاء الحاضرين جميعا. Thank you very much for inviting me and also for accepting my paper in this East Yemeni Urological Conference. I will talk today about the use of temporary membrane-covered self-expandable metallic stent. It's called UVENTATM stent for the treatment of recurrent bulbar urethral stricture. So I have nothing to disclose and no conflict of interest in this presentation. The outline of my presentation, I will talk about the general introduction in the management of bulbar urethral stricture. And also I give a short concept on this temporary membrane-covered self-expandable stent, the UVENTA. I will refer it as UVENTA in my presentation. And a short video about the method of deployment of UVENTA stent. And finally, I will present our data and experience with UVENTA stent. So as all of us knows that management of anterior urethral stricture, there is a lot of variables that control our decision. And planning for this management should be before going to the surgical procedure. And we know there is a lot of characteristics that play, change our decision. The first important thing is the stricture characteristics, including the location of the stricture, whether it's in a penile, bulbar, or panurethral stricture. Also, the length of the stricture, and as we know that, for example, visual urethrotomy, if the stricture is less than 1 centimeter, it has a better prognosis and less recurrence than more than that. And also for open surgeries. The caliber of the stricture is very important because it reflects the degree of spongiofibrosis, and more spongiofibrosis means higher risk of recurrence. Number of the strictures is very important. Stricture etiology, and also it was found that idiopathic urethral strictures has a higher recurrence rate in comparison to the others, and basically because we don't know the reason. And previous intervention, the number and the type of the intervention. The second thing, which is the patient characteristics. Our patient is very important, the age of the patient, the fitness, the comorbidities. And after all of this, the patient counseling, which is very important. We need to sit with the patient, we need to talk with him, give him the options, pros and cons, and finally, he's the one who's going to take the decision. The options of the treatments, we know that we have digital visual urethrotomy, urethral dilatation, plus minus urethral stent insertion, urethroplasty with all of its types, perineal urethrotomy sometimes, or even only catheter insertion. So from the previous literature, DVIU actually has a recurrence rate ranging between 8% to 77%. And we can notice that this big gap in the recurrence rate actually in the literature is due to the different characteristics of the stricture as we described before. And also urethral dilatation almost has the same recurrence rate. And then one of the important studies that done by Steenkamp shows that DVIU and urethral dilatation almost has the similar, similar recurrence rate. But in most of the literature, it was shown that more than 90% recurrent rate after repeated urethrotomy. And it reached in some of the literature to 100% after the second urethrotomy. Urethroplasty is still one of the less recurrence rate surgeries with recurrence from 20 to 25%. So urethral stent, actually, there is a lot of types of urethral stents used for management of urethral stricture, including permanent and temporary. And the main aim of the urethral stent is to oppose the wound contraction after dilatation or DVI. Temporary urethral stents actually showed that it has a significantly longer stricture-free survival in previous literatures, but permanent urethral stent has a unfortunately higher complication rate and failure rate, and also it makes the subsequent urethroplasty challenging and difficult, especially if it fails. So here is the important characteristics of the UVENTA stents, that it is fully covered with silicone from inside and outside, and this will prevent the ingrowth of the tissue to inside the stent. Second is that it is self-expandable. It has anti-migration barbs. It has a radio-opaque markers to help in insertion, sometimes if you use it under fluoroscopy. And also it has a retrieval suture that you can use it to remove the stent easily. And finally, it is preloaded in a delivery system that make it an easy for its deployment. Here is a short video in our institute about the insertion of the UVENTA stent. Here is the urethrogram, which shows there is a severe narrow bulbar urethral stricture. This is with the use of the cystoscopy. We insert the guide wire. Actually, we used to go with the small 6.5 French ureteroscopy through the urethra to check the length of the stricture and also mainly to check its position regarding the external urethral sphincter. You can see here it's multiple urethral strictures. So DVIU at 12 o'clock is carried out. So now after the visual ureterotomy, we are inserting a guide wire, which is 0.035 French, that is more compatible with the delivery system of the UVENTA. This is the delivery system. There is a different sizes of the UVENTA ranging from 3 centimeter to 10 centimeter. We used to irrigate it with saline to make it more hydrophilic. And we can see here, this is the lock system for this delivery system. We will release the lock, then we just push it and pull the cover of the UVENTA stent during the insertion. So we inserted the delivery system through the 22 French cystoscope. We go to the bladder, then we come back. It's very important to locate the site of the external urethral sphincter before insertion of the UVENTA stent, because we need to insert it distal to the external urethral sphincter. This will minimize the post-operative urine incontinence. Now we start to release the stent. You can see how it's covered with the silicone and it is self-expandable. Now we can go even with the 22 French cystoscope through this UVENTATM stent, and again we need to check again the site of the stent in relation to the external urethral sphincter. Sometimes if it is, extending to the sphincter area, we can readjust it or pull it outside. Also, we are asking the patient to cough or to strain, so we can, it helps us to identify the site of the sphincter. So this is the uroflowmetry with a good urine flow post-operative while the stent is inside. So our objectives is to evaluate the outcome of this UVENTATM stent and also to determine the stricture-free survival time from the time of the stent insertion and to assess the complications of this UVENTATM stent. So we had 22 patients between 2017 to 2020. All of our patients had previous urethral surgeries, whether dilatations, repeated DVIU, or urethroplasties. And our selection criteria was for bulbar urethral stricture and the stent insertion time between 3 to 4 months. Our exclusion criteria were penile or posterior urethral stricture or any pelvic surgery or radiation. So demographic data were collected, including the age, etiology, location, number of the stricture, the length, number of previous urethral surgery, and the maximum urinary flow rate, whether in the preoperative time, during the UVENTATM in situ, post-operative at 3, 6, 12, and 14 months. Our failure is defined as Qmax less than 10 ml per second, and also this needs to be confirmed with urethrogram or diagnostic cystoscopy. So from the results of our study, the mean age was 52 and the mean stricture length was around 2 centimeters. The mean of previous urethral surgeries was 3. We can see here that the range between 2 to 11 surgeries, that means the minimum patient that we did for him this surgery is 2 previous surgeries. The number of the stricture, this slide actually it shows how severe was the cases that we had. 14 patients with a percentage 63.6% had multiple strictures, and also 14 patients with a percentage 63.6 had previous urethroplasty, failed urethroplasty surgery. The causes of the stricture, 14 patients due to iatrogenic and 6 patients has due to idiopathic stricture, and 1 for infectious and 1 for traumatic. So successful deployment was carried out in all patients. We didn't have any intraoperative complications, and spontaneous voiding happened in all patients after the insertion, with a median follow-up for our patient was 17 months. The complication, 8 patients has positive urine culture, but we didn't have any patient with febrile UTI. Urine incontinence was in 8 patients, and actually all of them was temporary. It was resolved after removal of the stent. Feeling foreign body was in 1 patient, and incrustation was in 2 patients. Unfortunately, one of them was a very educated British man, and who stayed with the stent for around 1 year duration, refusing to remove it because he was feeling very happy. And the second patient was actually missed for follow-up. So the maximum flow rate, we can see here in this chart that the maximum flow rate in preoperative was 7, then during the stent in situ 23 ml per second, and it's maintained a good flow rate and during the follow-up period up to 24 months. The outcome, which is the main important for us, so out of our cohort, which is 22 patients, 13 of our patients had no recurrence in this main follow-up 17 months with a percentage of 59%. This is the Kaplan-Meier curve, which showed the mean stricture-free survival time from the date of the surgery, which was 27 months, and this is actually a very good time in comparison to urethral, dilatation or DVIU, which does not exceed even 2 months. And also, this is also the mean stricture-free survival from the date of the stent removal, which is 20 months. So, in conclusion, the success rate for temporary urethral stent placement has remained 59.1% at a median follow-up of 17 months. Actually, the stent maintain a urethral patency significantly longer time than dilatation or internal urethrotomy alone. It has, in general, a favorable side effect profile, and actually, it's very important that still we need a controlled studies with large population for fully evaluate the outcome. So this is some of the photos in my from our previous conferences. Thank you very much, and thank you for all my colleagues and also for the organizing committee.
Thank you very much, Dr. Ibrahim, for this interesting lecture. And there is any question? Yes, Dr. Ibrahim Nuno.
Assalamu alaikum. Thank you very much, Dr. Ibrahim, for this lecture and information. As we know that this idea is an old idea and used the gold material before, and now the silicone material. And I'm speaking about the incrustation. You have 2 cases with incrustation. It is easily to be removed or retained in the urethra. And what's the management of retained in the urethra?
Yes, thank you very much, our Prof. Ustad Al-Qadir, Dr. Ibrahim Nuno, for this very important question. Actually, the 2 patients with incrustation, as we said, they were missed. One of them was happy, but the good thing that we could manage to remove them easily. We used the lithoclast, it was incrustation from inside. The good thing that there was no ingrowth of the urethral tissue for outside that prevent its pulling out from the urethra. So when we just fragment the incrustation inside the stent, we just then easily remove it.
Thank you. Yes.
It will not lead to more stricture after removal, and you can exchange easily.
Do you mean the encrusted, Prof?
The encrusted stent.
Yeah, the encrusted, actually, one of them, we, after we remove it, we insert another one in the same session, just to keep the patency, because he just, accept for removal if we insert another one. This is one of them. The second one was removed easily, and he kept actually good flow rate in the follow-up period.
But the length of the stricture the same or increasing?
In the recurrence cases, it was almost the same, but there is some increase. But for those who have success and this was removed, it was both of them was success actually.
Thank you very much, Dr. Ibrahim.
Thank you.
I have one question about the expensive this stent.
Yeah, actually, unfortunately, it is a bit expensive, you know, especially here in Gulf countries, you know, it costs around $1,400 actually, this stent.
Thank you. دكتور وليد لو أصبح تفضل دكتور.
طبعا سعيد ان انا شفت الدكتور ابراهيم النظاري من احسن الناس وافضل الناس خلقا وعلما.
حياك الله دكتور وليد والسلام.
حالات كثير كنا في القاهره مع الدكتور عبد الوهاب قصي الله يذكره بالخير. اليورثرال انكرستيشن زي ما كنا ناخذ الدكتور ابراهيم حالات كثيره ما كناش نستخدم هذا الستنت، هو قديم طبعا ما هوش فكره جديده. كنا نتناقش الدكتور ابراهيم قال بس يمكن الماتيريال تغيرت. كان يستخدم في حاله الالدرلي بيشنت اللي هو نوت سيوتبل فور سيرجري، وكان يستخدم في البستيريور ريثرا ولا نوت في الانتيريور ريثرا. انا مستغرب ليش يحصل الانكونتينانس وانت شغال في البلبر، يعني حتى لو تاثر الاكسترنال سفنكتر ستيل هي هاز انترنال سفنكتر. البلبر urethral stricture الان amenable and easy operations من ناحيه الurethral surgery. We can use buccal mucosa او even unibidical benign island flap. الطول يمكن نوصل ل 18 سم. الديورابيلتي حقها على 15 سنوات توصل 90%. يعني حكايه ان احنا نستخدم ماتيريال زي كذا صح انها ايزابيليتي. ارتحت انه الحالات المستخدمه كانت فوق في السبعينات و75 يمكن قد يكون نوت امينبل فور سيرجري، لكن ستيل بالبر يوريثرا 95 99% لو عملنا تو اند انستوميدد وكان نستخدمه حتى لطول 2 سم. اذا كان elderly patient has erectile dysfunction وما يهمش انه يحصل كوردي ممكن مور ذان. فقصدي هذا بيكون لاست يعني تريتمنت او حاجه اذا كان المريض نوت فوت بير سيرجري. otherwise you can do perineal urethrostomy. patient will be continent مع external و internal sphincter. فايزي ان انت تعمل هذا. الكوست اللي قلتها غاليه والديورابيلتي جاست 1.5 years not sufficient ان احنا نعملها. مع احترامي هي فكره كويسه بس لإلدرلي بيشنت نوت امينبل فور في الانستيزيا. واعتقد هذا خدرتهم كل الحالات صح؟
Yes, Dr. Walid, exactly. You are completely right. The urethroplasty is still gold standard actually. But as you noticed that most of our patients were elderly. This is one thing. And actually also 14 of our patients had previous failed urethroplasty. And it was buccal mucosal failed urethroplasties. And in addition to that, they have a multiple. So it is a complex cases that, as you said, we need to, if it is like a second option, but still, this stents, unfortunately, we are using them only in a complex cases. We could not compare this stents in all of the studies actually with a fresh, short stricture. And I think if there is some comparison, it may have a good result with this new materials. Thank you very much.
Thank you very much, Dr. Ibrahim. Close. Thank you.